Hello, my name is Marc Ryan. I'm Chief Strategy and Compliance Officer for MedHOK, and welcome to one in a series of podcasts. Today's topic is the Coverage Determination, Appeals and Grievance 2015 Audit Overview. As many of you know, there have been new audit universes issued by CMS, and it creates increasing complexity for plans and other entities that are required to respond to audits by CMS. First, the number of audit universes have increased dramatically in 2015 with the publication of the new universes by CMS. The CDAG universe itself has 15 audit universe reports now versus just 3 in 2014 and before. The chief aim for increasing the number of overall universes was for CMS to better ascertain compliance with all regulations. So this should be seen as a precursor of even more sophisticated looks at audit universes and documentation in the future. Plans obviously were not yet used to the new universes, which created a number of issues on audit. In a general sense, plans should always use the best practice of running universes early and often, so that when these universe requests come in for audits with CMS, your staff is very versed in responding to those requests and that there is a good amount of accuracy to them. However, because the audit universes were only a few weeks old, CMS had a number of clarifications they were making to the universe pulls, which necessitated a number of reruns. As many of you know, in general, if there are deficiencies on audit universes pulled for CMS and there is required to be more than 3 runs, you generally are getting an immediate corrective action on audit for that universe. It appears that given the fact that clarifications were needed by CMS and because the audit universes were so new, that the situations for reruns related to the clarifications are not being counted against plans right now by CMS. So ICARs are not expected for deficient universes as long as it's related simply to the clarifications. In general, the audit findings so far that we've been involved with seem to echo what we already know over the past few years. We see these in many best practice memos, annual audit briefings, as well as civil monetary penalty letters, which continue to be posted by the week by CMS on the CMS website. We will say, however, that CMS is more closely scrutinizing a number of areas in 2015. CMS is spending a great deal of time upfront to validate the universe, which is something really new this year. Plans really need to have a very clear focus moving forward on validating your universes to make sure that they are valid over time. Again, we haven't seen many ICARs so far based on the validity of universes, but this new trend will mean that those ICARs may be much greater in the future. And in general, CMS is still very frustrated on audit with the lack of adequate documentation of cases and really want to see it very well assembled and, if possible, all in one system, so there's ease of use for the auditors and the ability to begin moving quickly through the audit requirements. Misclassifications continues to be a major focus of CMS even in this year for CDAG. Oftentimes, as you know, redeterminations are inappropriately classified as coverage determinations at points. For 2015, CMS appears to be zeroing in on duplicate cases and the appropriate creation of redeterminations in this case. So plans have to look very clearly at duplicate cases, determining if in fact perhaps it's a duplicate fax or not. But if it's not a duplicate fax, it really should be opened up and created as a redetermination. Again, consistent with past audit years, there's close scrutiny of outreach for required medical documentation. And this is becoming even more robust in 2015. In a general sense, CMS feels that there really should be no denials for lack of adequate medical documentation. We know that that's probably something that is not going to occur in the near term, so CMS is really focusing in on 2 different areas right now to ensure as few denials for lack of adequate medical documentation as possible. First, they are now expecting the plan medical director to reach out to providers that are not providing clinical information. The rationale here is that if a clinician calls a clinician, there's a better chance that that provider requesting the authorization will respond and, in fact, turn in that clinical documentation. And as we've seen over time, they continue to raise the bar on the requirements for adequate outreach before denial. Again, the goal is no denial for lack of adequate medical documentation, but in this case, CMS is again zeroing in on requiring at least 3 or more clear attempts at gaining that medical documentation before a denial for lack of documentation is made. And those attempts really have to be done at different points in time within the life cycle of the case. For example, they may require you to send it out on one day in the morning and the next day in the afternoon, and perhaps in the final day if it's a regular coverage determination, perhaps at a time in between those hours. So CMS is really, again, closely scrutinizing outreach to limit denials for lack of required documentation. The focus on clear and concise correspondence continues this year, as we've said in the past. As has been said in the past, denials must have a very clear, concise reason for the denial and the next steps a member can take in that appeals process, from what are the appeal rights to how they go about it. And again, a very clear, distinct, concise reason for the denial so that the member can work with the provider to perhaps make a better informed appeal. A new trend here is that CMS is also requiring, even with approval letters for a coverage determination or redetermination, that there is clear language regarding any quantity limits that are on an approved medication. So plans should really, and PBM should really look closely at this as well, because that's going to be a new finding moving forward. Formulary administration, as many know, has been a very, very wide-ranging activity for CMS, and it in fact is one of the largest share of overall audit findings and civil monetary penalties out there. And again, consistent with prior years, everyone is being encouraged to follow those transition policy guidelines very closely, and following it to the letter is a very paramount concern for CMS this year. We did have a comprehensive blog regarding all audit trends recently. You can see the hyperlink here, or you can Google MedHOK University YouTube and look at our August 2014 entry for much greater details, not only on CDAG, but as well as on ODAG as well as model of care. To learn more about MedHOK, MedHOK stands for Medical House of Knowledge. Please go to www.medhok.com. You can read or watch our blogs, compliance newsletters, and podcasts at www.medhok.com/blog, or feel free to search MedHOK University on YouTube. You can subscribe to our blogs by visiting www.medhok.com/blog. You can read a blog and press join our mailing list at the bottom, or email us at compliancenewsletter@medhok.com. Lastly, just a little bit of an overview on MedHOK. You can see that we have a care, quality, and compliance platform. It is a single platform that all users work in. You can see a number of different modules here, from prior authorization and care management to a HEDIS certified engine, as well as appeals and grievance and complaints tracking module, and a member and provider portal. Thanks again for joining our podcast. Take care.